My name's Mark Abrams. I'm from Charlotte, Iowa, Nose and Throat, and I'm here to talk to you about migraines and a block technique I have worked with in my clinic. I think it's been instrumental in managing these patients better, and myself included, being a migraine patient. I've always found these patients interesting and challenging at the same time, but it never delivered in terms of satisfaction because it was always difficult to do, and I always felt like I was being a neurologist without the proper training to be one. Having said all that, we see a lot of these patients, and we're seeing even more of them since the COVID pandemic uh, has occurred. There are some really good reasons for this, and I discussed this last year at our national meeting, but I'm going to leave those towards the end of this talk because I think I really want to focus on the block and how it works itself and some data that we've been able to collect during that year's time as we've explored how well this modality works. It turns out that what I'm going to tell you today isn't really all that complicated. In fact, it's quite simple, and I was astounded when I did my literature search to realize no one else was doing this. That's when it became compelling to me to actually get this out there. It's simply a simple thing that basically everybody has the training that does otolaryngology can do. They have the equipment already in their office and the materials. It's just a matter of trying them and learning how to do them. But this is simply no more difficult than prepping a nose when you're doing a sinus case, and most of us do those. And endoscopic training is pretty much standard nowadays, and those who don't have the training, this is not difficult. We're not asking you to operate an ethmoid sinus or remove a pituitary. We're just trying to get cotton in the right place in the nose because we're all wired the same way. And it's compelling when you understand what these do and what the sphenopalatine actually gives us access to. That's where it becomes quite interesting. And the things that happen once you do these and realize, oh, yeah, that was probably migraine too, or something that was not otolaryngologic that we didn't have a good answer for, it becomes pretty fun. And so let's learn about this. Let's try it. I think as otolaryngologists have a role to play in these patients, and we certainly have a window we look through that's very different than the other folks, the neurologists, the dentists, the neck specialists. We need them, but they need us too. And so this is where we can really play an active role. So without further ado, let's go through the slides, and I'll try to not make this laborious so that you can get through this in an hour. So basically, the reason for this slide is to give credit where credit's due to Claire Burgess and James Peden, whose efforts in this project of doing a lot of cranking of numbers and chart review has been instrumental in allowing me, being a clinical otolaryngologist, to be able to get this research done. There's really no disclosures because that's the best part of this. There's really nothing proprietary we're using with any of this. This should not involve insurance companies or drug companies getting in the way. So these are our bunch. We see the patients that don't think they have migraines, and neurologists do. That's what I always tell my patients. This is a great Halloween costume for a lot of conditions: sinus, dizziness, ear pain, dizziness, tinnitus, odors that are coming out of nowhere, and other transient neurologic symptoms that we don't have a good explanation for: the clicking in the ear, the hyperacusis, the red ear, a lot of these things that we see all the time. We've always wondered what's going on. And it turns out we do a lot of evaluations and spend a lot of time in management, and so do the patients because they get the wrong diagnosis and use the wrong treatment. And then we're stuck trying to straighten them out, essentially to tell them what they don't have: a sinus infection or peripheral vestibulopathy or an ear infection. What they have is a migraine variant. And what they don't have is the right diagnosis and treatment. So then we're stuck with the situation of telling them something that their primary doctor didn't tell them, and now they don't know who to believe, and we're stuck trying something that they really don't necessarily believe is what they have: a migraine sometimes, and you have to try migraine medicines, and that's not where our treatment is very rich. The neurologists and psychiatrists are good at that, but they have a tough job anyway, and we're sort of amateurs in that. So why not do something that we do well? And that's work inside the nose. And that's where this becomes compelling because otherwise they have to go see a neurologist and they're booked 3 months out and they're still not convinced and they just want a stronger antibiotic. So the problem is that, people don't know sinus well. The doctors and the patients aren't very good at this, and we knew this. We had a classic study that came out in 2007, the SAM study, that basically looked at 100 sinus patients and had them CAT scanned and evaluated by allergists, otolaryngologists, and neurologists, and found to have migraine variants and negative CT scans 97% of the time. Only 3% of these patients got it right, and only 22% of their primary care doctors got it right, which means people really don't do this well. And that's because people don't confirm sinusitis with a CAT scan, and you can have migraine and a sinus infection at the same time. So it's not always that truly helpful sometimes. So, what's going on here? Well, the Summit study gave us some information which was fairly useful. They looked at about 3,000 sinus patients, and what they found that had headache is that these patients had a lot of sinus symptoms. They had pressure, they had drainage, they had pain in the right places, not just behind above their forehead or on one side. It was behind their eyes and it was on both sides very commonly. And they were accompanied by eye symptoms. Where are these eye symptoms coming? The tearing, the lid edema, the ptosis, the conjunctival red eye. The patients are stopped up and running. I mean, that's because that's what the SPG does. It gives parasympathetic juice not only to the nose, but to the eye socket and the lacrimal gland, but also to the palate as well. So they make a lot of drainage. And these are fairly miserable patients. These are patients that aren't getting better, and their MIDAS scores show it. 73% are in the 3 to 4 range, and the HIT 6 is over severe. And so, what just is a migraine? Well, so far, the neurologists have created diagnosis for us. That's still not exactly as clear as you would like. It's one of those things that has sort of a multiple choice question component to it, which makes me think that maybe we just don't truly understand this. And it became very stereotypical, the bad headache that everybody thought about made them go to bed. And oh, it can't be a migraine, it's not that bad. But it really didn't say that it had to be that bad. It was just a possibility because it says it just has to be recurring, at least 5 attacks. It needs to have duration, at least 4 to 72 hours. That's a pretty broad category, and at least two of the following characteristics: unilateral location, pulsing quality, isn't always there, moderate severe pain intensity. The older patients don't have that much headache, aggravation, or causing avoidance of routine physical activity. Well, that's a lot of things that make us feel miserable. So it's not necessarily very specific stuff. And then you add on nausea and vomiting, which is helpful, and photophobia and phonophobia is helpful, but it's not always present because remember, notice it's only one of the following. And some of these patients don't even fit this definition at all. And that's why this is sort of a diagnosis of exclusion because it's not accounted for by another specific ICHD3 diagnosis. What you'll find when you start seeing these patients is that they really don't fit the bad headache box a lot of times. In fact, it's more of a mild headache or not that much headache at all, and other neurologic symptoms that they're actually seeing you for. They got the vertigo, they got pain in places which masquerade as other things like earaches and sinus infections. And they've got neck aches and they got tinnitus and they got phantom smells and they got a bunch of other things which are basically neurologic misfiring because that's basically what a migraine is. It's more of a brain cramp that can turn into a headache and it occurs when there's accumulated triggers that overcome a brain's homeostatic state. And it's not just a headache, it's a whole event. It's not just the main event, it's a warm up band and getting out of the parking lot. You got a prodrome, you got the R excitation phase of cortical spreading depression they talk about, which basically short circuits the brain's functionality in those locations, and it crosses the brain like a tsunami between 20 minutes and 3 hours. And during that time, the brain has aura, and that can be any sense or any motor function that could be changed in its ability to function. And then once it breaks that threshold, there is an attack, and that's where the headache occurs, but also sometimes loss of function, where there's a neurologically complicated headache, followed by a bit of a hangover. But if you think of migraine more as a threshold disease, like a seizure, it makes a little bit more sense. The brain has a homeostatic state that's based on hydration, protein, and sleep, essentially, plus various triggers, dietary, other things. But genetics and acquired disease states make what's going on inside the brain a little bit difficult to manage because there's not a real good way to specifically get to a particular part of the brain and make it better without sometimes causing problems elsewhere. So no matter how complicated the ion channels and neurochemical imbalances are, it's really, you know, um, difficult either way. But if you know that we're wired the same way, we could turn off the on button of pain going to the brainstem. Imagine what that might do. It would probably turn off a lot of the triggering for what's causing the brain to reach that state. So that's how blocks work. And so neurologic hyperexcitation reaches its point where it breaks that threshold. And if it's a migraine, it's cortical spreading depression. If it's a seizure, it's synchronized firing. And so they're very similar. It's just one goes off the rails, and that's a bigger deal. Either way, they're a big deal because they both damage the brain over time. And brains become chronically impacted by these things, and that's chronification of neurologic illness. And that's when they become much more difficult to treat because you get pathways that are now much more upregulated, that need to be downregulated, they're maladaptive, and injury. So, what about learning about this? Well, there's a great course. I took the Migraine Toolbox course. The Association of Migraine Disorders has released a new version coming up, and I think it's a great resource. And this AMD website is fantastic. Rick Godley did a beautiful job putting that together, and there's tremendous resources that are free and a forum for discussing interesting cases. And I highly encourage anybody who's watching this program to become a member of Migraines and Otolaryngology Society. It's a great way to get involved and learn. What we found is patients, if we could do this, it would probably work, but people don't like needles. And they're usually not in a situation where they can get these very easily. A lot of neurologists don't do them, and they're basically the only people that do them, aside for some pain doctors and primary care doctors and venturesome dentists that actually try these. But basically, it's relegated to last case use because of insurance companies being in the way, and just not enough people doing them. So patients much rather try pills than having something unusual stuck up their nose or needles put in their neck, but they really work. And I think at some point, patients just would rather just find out what's going on instead of being sort of a brain guinea pig. And that's where we get sort of medication fatigue with these patients. And the pill model really starts to break down when you don't have a good way of choosing the right pill to choose. So why not? They seem very important. It was one of the three basic tenets of treatment according to the Migraine Toolbox course: homeostatic brain balance, neurochemical balancing after that, and then using a block to turn off the on button to reboot the neurochemistry and neural circuits of the brain. That's a powerful thing if you think about it. That's the first thing we do for any electronic device when it's not working well. We control alt delete, and that's very attractive logically, and it does bear out good data that it works. This is nothing new. Our targets are classic. We know these targets. We use these targets every day when we do sinus surgery. Sphenopalatine ganglion, anterior ethmoid nerve. We know where they're at. We know they're accessible through the nose just with injections. But the nose is really good at absorbing medicine, so why not topical treatments? Problem is, so far, every technique's been sort of blind. They couldn't see what they're doing. But the occipital nerves are an area that's easy to find, and they're not hard to do if we want to block them. It's just not an area that we typically pay much attention to. The back part of the neck, that's sort of an area that we just sort of ignore and relegate to the spine doctors. But sphenopalatine ganglions, they really work when you block them. And they're sort of the holy grail of blocks. Why? Because they not only have pain fibers going through there, but they're also the circuitry of both ends of the autonomic nervous system, the parasympathetic and sympathetic fibers that traverse that ganglion. And Greenfield Sluter knew about this, and he did this a long time ago. He's one of our guys. Back in 1908, he first did one. He used cocaine in some cases and alcohol to ablate the nerve. Either way, probably using a head mirror and a candle behind the patient or a light bulb, he got good results. In fact, he became almost his life's journey to find out ways of using this thing once he started realizing what all works. It was much more than just, Sluter's neuralgia he was treating. He was doing sphenopalatine blocks. And, published in JAMA in 1913, actually became the chair of WashU in 1930. But then along came aspirin. It became much more fashionable to take a pill than having something strange stuck up your nose for a migraine. And that made sense. But eventually, things just didn't work with the pedal model that well. I mean, the worst, best things we had at some point in the 1980s was the ergot alkaloids, Fiorset, and things that are pretty lousy actually, and not particularly safe. And so Milton Reeder sort of rediscovered this in the 1980s in New York City and started doing these. In fact, met one of his patients about a month and a half ago, and she was really funny and said, yeah, he did that SPG block on me, and yeah, and got great results a long time ago. She came in for sinus, and but then Geraldo trying to shut him down, thinking he was using cocaine. He wasn't using cocaine. He was just doing, lidocaine SPG blocks, and he was a nice guy. But that Geraldo, he always tries to get people. But anyway, that was her thing, but it was really cool because I got to meet one of his patients, and he's become fairly chronicled. There was a book written about it, and it's probably not a bad read. But we don't have time for that, but we do have time to try to manage these patients because we need a better way. Because when we look at our schedule every day, we look at dizzy, dizzy, dizzy. I got sinus, I got ear pain. I was like, okay, it's a lot because these are time consuming anyway. So we need something that sort of can help us out, a little shortcut. Otherwise, they keep coming back and not being better. So how hard is this? Well, it turns out that all the studies you look at, whether you anesthetize, ablate, or hyperstimulate, they all seem to work pretty well. And the approaches have so far been not exactly great because this isn't a hard place to get to. Cerebellum is below the eye socket behind the maxilla and a tough place to get to around a lot of vessels and important stuff where, externally you can use long needles in strange places using fluoro and anesthesia and all that. And there's risk involved and you can't really see what you're doing and you can get okay results. And then there's intranasal catheters and swabs, which here again avoid all that risk, but there's still sort of a blind poke. We know our anatomy, but yeah, these people that are doing it don't know it as well as we do. And so it doesn't always end with an happy ending or get to the target. And then Dr. Dutton and Rodman actually realized that and tried this. They did a study using sphenopalatine and anterior ethmoidal nerve blocks using a spinal needle. I don't know how much they pay these patients, but they got pretty good results. 81% effective. That's good results. For migraine, there's not too much that works that well. And then catheter devices were developed because no one likes a needle in their nose, and this was allowed people like primary care doctors, Roger Katie, he's a primary family practice doctor, started doing these. The problem is you sometimes don't hit the target with this because these noses are narrow and crowded, and this is hard to get to if you can't see what you're doing, just knowing landmarks. You can get pretty decent at it, but many times you're just going to wind up missing the spot and just draining it down the back of their throat. And that's why they only got a trend here. And here again, the further away from the target, the worse you get. So why not use scopes and try to do these with non-needle type procedure? And that's what I started doing using cotton and lidocaine. And so here's our targets. The anterior ethmoidal nerve is the one that's often missed. This is the second target that no one really pays attention to. I mean, they do B1 blocks, but they're usually injected at the forehead, which is painful. No one wants that. Face is sensitive. I wouldn't want that, honestly. But sticking a cotton ball up in your nose at the highest part of the nasal vault, right at the head of the middle turbinate, just tickles, makes your eye tear, and makes you want to sneeze a little bit, but that's all. And it's powerful because of what it gets. It gets the anterior cranial fossa dura. That's powerful. Plus the forehead and the bridge of the nose, and it gets another button turned off of the on buttons because a lot of the headache driven from the nose is due to nociception created by pressure zones. And these pressure zones are what creates the turning on of these nerve fibers to create a persistence and building sense of pressure evolving towards pain. Just like having a tight shoe you've worn too long with bunions. And eventually you start noticing your anatomy and where it hurts. And SPG ganglion, here again, powerful stuff. You're going to the back end of the nose, but you're getting a lot with it. You're not only getting the nasal cavity and the sinuses back there, but you're getting the orbit and the eye socket, and you're getting the teeth as well. And that's really where a lot of these patients hurt. It really makes people think they have a sinus infection. In fact, we'll scan these patients and not get a result. Then we send them to neurology, and they're here again already been scoped by us. What if we just stuck some cotton lidocaine in there and didn't charge them for it? There's an idea because cotton and lidocaine don't cost anything, right? So that's how you get to do it because guess what? Nasal endoscopy is covered by pretty much everything Medicare, Medicaid, and commercial insurance on the fly. You don't have to get a pre-cert for these patients. I can't speak for every insurance in every state, but that's pretty much what I've found out. And then when you do these, you also get the posterior middle fossa dura, and that's really where this really sinks its teeth into a migraine and gets rid of it. And then what you also see is the rebound from all this parasympathetic and sympathetic maladaptive triggering. And so you'll see a lot of tearing and salivation and mucus and congestion in these patients. And that all turns off after the block, not just for that day, but for a little while. They catch up and they can start managing it because the neuroinflammation's been turned off. And the sympathetic pathways that are driven to a higher state over time by pain, which increases your norepinephrine and glutamate levels in your central nervous system and throughout, becomes highly triggered and highly anxious patients. High sympathetic tone, low serotonin, that's an anxiety condition. Add glutamate, that's a triggered anxiety condition. And the other thing that happens is you start feeding the circuit board more business and it starts upregulating as a result of that because that's how the molecule CGRP turns on the brainstem to a higher level once it gets triggered by pain. And once it does that, there's a higher idling state of pain in that brainstem. It may not reach the point of consciousness. Yeah, I heard because they just sort of mildly hurt all the time in their interictal phase, but it usually is indicated by a lower firing threshold of the nerves going to muscles like the ones around our jaws and the ones around our neck. And so these patients are typically tender in their masseter temporalis and their pterygoid insertion point, and also in their SCM and their trapezius muscles on the side, their head's hurting, because these are all receiving juice from the same place where the primary headache's coming from. And that's where the occipital nerves get involved. And they're important parts of this because if we don't turn off pain coming from there, we're not going to completely turn off the pain to the brain and coming from the head and neck. And that's where at least 25% of the pain's coming from in my experience treating these patients. And they're all due to worn out body parts, essentially. You know, we don't rest our neck because we're too concentrated on what we're doing, and we're a higher primate that uses our hands and our eyes and in front of our head, so our head's always down. And so you start putting the posterior neck muscles that support our neck during those exercises under strain. And if it doesn't rest at night from bad sleep positioning, these patients don't get right, and tight muscles pull on nerves that can't go anywhere and lower their firing threshold. So the greater and lesser occipital nerves are basically trapped in our scalp, in the aponeurosis lining of the scalp. And they go around the SCM, the lesser, and through the tendon, the greater of the trapezius muscle, and create a muscle nerve pain loop that basically becomes a vicious cycle because the more the nerve hurts, the tighter the muscle, the more the nerve hurts. And the brain is the audience to that through, you got it, this operator switchboard, trigeminal caudate nucleus. And when you're lit up all over the place, it's like New Year's Eve. Everybody's calling. And the brain is tied up with this busy signal at the thalamus level and in the sympathetic tone going to the spine. And this is a bad thing. You get higher anxiety, you get higher awareness because from the thalamus you go to the reticular activating system and you get emotion, anger and sadness, which turns up the volume because that recruits much more attention. And then there's a memory of the pain, which creates this feeling of dread with migraine patients. So it sort of builds on itself, becomes a sort of feeling of dread. And so that's why turning all this stuff off allows the rest of that stuff to just so go to bed because millisecond half-lives, that is the half-life of the neurotransmitters that are receiving the signal. So you don't have to turn this signal off long to have a profound effect of everything turning off quick and rebooting. So this is very attractive. Control Alt Delete. We've all needed a reset button, and it's literally been right underneath our nose. So we're ENT doctors. We work in the nose all the time. Why are we doing this? And that's not a bad question to ask, right? We have the tools and the knowledge. We're good at this. We just don't do it because we just haven't tried it, right? So I started trying it. My first patient comes in, COVID, couldn't get into the Sphenocath clinic at Duke. It's closed for COVID, and she was miserable because she had COVID. And that lights up headaches, we now know. And she was hoping that she had a sinus infection I could get rid of to at least alleviate some of her pain. So I scoped her and scanned her, and everything was fine. And I said, I think you got a migraine. You know that, right? She had dark sunglasses. Yeah, I know. Well, can you block me? And I said, well, Actually, I've been dying to try this on myself, actually. But if you want to be the first guinea pig on this, I don't think I can hurt you with this. All I'm going to do is put cotton and lidocaine in there and see what happens. Because that's what occurred to me that it probably would work. And so I tried it. And in 5 minutes of it, she turns around and says, "Holy crap, Doc." I said, "Okay." I was just typing on my computer and I said, "You okay?" And I was a little nervous, you know. And she said, she whipped her sunglasses off. My light's not even bothering my eyes. This is the best block I've ever had. My headache's gone completely. It never gets gone. It did. So I said, huh, I wonder how long this lasts. So I didn't see her for weeks. It was 6 weeks before her headache started even coming back, and 3 months before she started getting back in earnest. And her blocks at Duke didn't last that long. So I'm thinking, okay, this is probably the way this needs to be done. And started looking around and say, is anybody else doing this? This seems pretty easy. I mean, clearly I'm not that brilliant, I don't think. And so and I was astounded. No one really has been doing this. And it just tells you how much ENTs, doctors just really aren't that interested. This is like trying to talk your toddler into eating green vegetables. And that's what these talks are often like. Yeah, that's great, Dr. Abrams. You can see these patients, but there's too many of them out there. We need to start taking the ball and running with this. And so this isn't that hard. And this is the algorithm I use, and this is really easy. You suspect a migraine, block them. Got a lidocaine in there, you got to look at their nose anyway, because usually they got sinus. And it's going to tell you a lot too. When you look at the nose thoroughly, you'll understand a lot, and I'll tell you why, because the nasal anatomy tells you the story. And then, if they're still hurting, assess their occipitals as part of your process, because then if you block them, you get great results. And if that doesn't work, then you know they need an MRI, because it's got to be inside their head if it's not coming from outside their head. And then you get them to see neurology so they can get their head examined. There you go. So here we go. So how I do it? Well, not that difficult. Really, don't get intimidated by this. You should be able to do this tomorrow. This is easy. There's a learning curve like that. So you prep the nose with atomized lidocaine and afrin, and then you wait 5 minutes. You can use tetracaine and eosinophrin, doesn't matter. And then you take that time and use it wisely. The biggest barrier to doing this is the time it takes to sort of explain it and do it, because it's going to add 15 minutes to a visit. So if you don't have that time and the way you do scheduling, relegate it to your PA. It's easy to teach them. That's who does my blocks. Or you can have just a separate, afternoon to do them or morning to do them. That's what I do. I call a block clinic, and they're easy. They help. Just tell them to call and ask them, what do you need? And you'll write down if they're following up what they need so you can have it ready. So it should be in and out, easy thing to do. And so, not much more time it takes than do a skin biopsy. We do this all the time. So here we are. You check your occipitals, your pterygoids, and your V1 V2 as part of your process. Make it part of your process, because you'll use palpation of these areas to sort of let you know where to look for the problem, and then where to assess afterwards to see if you got the job done. Then you give them some literature to read, prepare your pledgets, and give them a lollipop or mint, because lidocaine doesn't taste good, and they get sort of dramatic when they feel the numbness in their throat, and this sort of mitigates that. And then finally, do it. Use a zero-degree telescope just like you do any scope in your office. And if you don't, this is not something difficult to do, and it shouldn't have to be that expensive, because pretty much everything most people have, they already have. You may not have a micro alligator, but those aren't expensive. And you don't necessarily need a sinus telepack. Those things are expensive. You can get a laptop and an adapter and a camera for about $2,500. And I can tell you how to do that with non-proprietary equipment, what my partners did. And it looks like he does a great job doing these. I don't have that yet because we are equipped with the telepack. And I have two screens, because you want a screen for the patient to look at, because they can learn something about their anatomy and where this is coming from. So these are the points I have my patients assess when their block wears off. And these are the points that I assess on them so they can learn about them when I'm evaluating where their pain is coming from. So if they have a forehead headache, you palpate V1, which is the supratrochlear or supraorbital area. V2, if they have midfacial headache, you're going to palpate the infraorbital nerve foramen. If they're having TMD or ear pain symptoms, you're going to palpate right behind the jaw. If they had recurring ear pain, antibiotics aren't working, and the earlobe drum looks normal, just feel their next, and that pretty much tells you the whole story. They'll wince and hurt right in their ear. And then finally, the occipital nerves are easy to find. They're between the mastoid tip and the nuchal tuberosity, which is easy to find on everybody, even if they have a head full of hair. And all you have to do is palpate on the cranium right above the edge of the occipital skull, where the nerve goes over that ledge, and just do mild or moderate pressure over the expected 1/3 and 2/3 points. And they'll usually wince, and you'll know that's a spot that's positive, and mark it with a skin marker so you don't have to go fishing around looking for it in their hair again, because that's where you'll inject. if you do an occipital block. So you educate the patient, ready them with their pledgets, and you give them a lollipop, and go ahead and use cotton balls about that size. You can use some with strings on it or neuropatties. And then, of course, this is how I just sort of prepare them in a kidney basin. And it's nice to lay your pledgets on some gauze before you put them in so they aren't sloppy wet. That'll avoid the numb throat and the worry about aspiration. I've never had one over 5,000 blocks, but this is what I tell patients. Here's what you're going to have done. This is how we do it. These are the risks: the minimal risk of lidocaine and afferent allergy, side effects of getting lightheaded, and which is hardly ever happens, and then the risk of swallowing a cotton ball or aspirating one. So if there is any concern, these little cotton balls with strings on are cheap and easy to get. And I even gone through my samples from American Surgical, and I can give you a link to that at the end of the talk. But these are the target locations: your anterior ethmoid and your sphenopalatine, and that's where you'll put your cotton pledges. This is how I do it. I basically put two up front because those are easy.
Right up high in the nasal vault, about as high up as you can get it, just at the level of the head of the middle turbinate. And you'll place two of them in there because it's easy, and that way you can get a good block. Place it.
And these are easy to do. And so the sphenopalatine block here is the next block I'll do. And it basically is where I just ride the top of the infraturbinate right under the head of the middle turbinate between the turbinates and the septum with a small piece of cotton. You can use a string or you can just place it free as long as they don't sniff. And usually these things are in there pretty tight. Now, once the medicine starts working, lidocaine blocks the cholinergic input. They've already been aphrodized. Their nose is basically cadaveric, numb and wide open. Lots of times that's when their cotton ball will be a jumper. It'll jump down the back of their throat. So you tell them if they feel it, just to go ahead and spit it out. And you give them a little Kleenex that they can spit it in. And if they have a string on it, all you have to do is pull it out. So what do you do at the end? Well, you check them. You ask them, are you better? Yeah, well, you're done. Or is the other thing you came in for, the dizziness, better? Yeah, well, okay, that's what it is. Then, if it's not all the way better, check your spots. B1, B2, pterygoid, left greater occipital. If they're still sensitive there, that's where you want to look. If it's up front, then you look at your cotton balls. You can replace them or you can reposition them. I call this a two-putt. This is like a dog leg on the golf course if you have one of these really deviated narrow noses, because you're basically just placing that second cotton ball at the sphenopalatine target basically sort of blindly until you reach some resistance. You'll either hit a spur or you hit the rostrum. You can sort of tell by how deep you are. And at the end, now you can actually see what you're doing, and you can actually then carefully replace the second cotton ball or just sneak the one that's in there underneath the spur or above the spur to get it to where it needs to go. And usually within 30 to 60 seconds, their pain will go away. And it's pretty impressive how quick it is because it tells you how close they're already there. And the data basically reflects that. The average time it takes for an average mucosa to translocate local anesthetic, we know this, there's data on this, is about a minute. And then it takes about a minute per centimeter to travel along the axon. And so once that axoplasmic flow delivers to the ganglion, which is about 5 to 7 minutes on average, their pain will start melting away. And that's how it feels when I get mine done. And it's sort of the only way to know how these really feel, including the calm you get from having all the pain turned off, is to actually have them done on yourself. So if you happen to have migraines and you're that unlucky person, you actually are lucky because then you can have your partner or PA try this on you and they can learn how to do it too. And then you can actually show yourself what actually happens when you do these, and you'll learn a lot by doing that. But the occipital blocks here again, I get these a lot too, and they're wonderful, and they make your neck completely from going from being stiff and limited to not stiff and not limited. And they don't hurt back here, and that's that distribution. So if you're not all the way better, the occipitals are still tender, then inject them, and it's amazing the results that'll improve once you've done that too. But if you've done all that and they're still hurting, then an MRI is where I go next, or CT if I think it's their sinuses, just because I have one of those in the office, and that'll just make things quicker. But the neurologist needs to see them anyway. And if you're not sure, never let your guard down and miss a dangerous headache. So these are occipital blocks. This is pretty standard. Use the landmarks we already know. Other targets, the great auricular is very useful as well. About 5% of my patients need a shot there too. And the third occipital, occasionally I found that to be the patients that have already had posterior neck surgery, that sometimes they're having, post-surgical neuroma type pain, and they will actually do well when I block that. But in any event, this is easy. Just buffered lidocaine followed by Marcaine. Buffered lidocaine, you're taking maybe half a cc of local and using 1 to 10 dilution of bicarbonate, and it works in 20 seconds and it burns very little. The 30 gauge needle hardly hurts at all, and the burn is very brief and very tolerable. Once you've gotten a good numb corridor, then the 25 gauge needle can then be used to fire in about 3/4 to a full cc of bupivacaine, quarter or half percent. So this is a very small amount of local, so the risk of local anesthetic toxicity in this case is very, very low, even with bupivacaine. So that's really not a concern. The amount of local we're using in these cases are far less than we use in routine other things we do. So that's not a concern. And this is extremely safe and easy to do. This is easier than starting an IV doing occipital blocks. They'll literally tell you where they're tender and they're not hard to find. And then once you've hit the spot, it's very forgiving because it sort of spreads out once it gets to the subgaleal plane and pretty much knocks it out pretty reliably. You don't want to skewer the nerve, so you're going to stop just short of it when you inject the Marcaine. And then finally, once you've done all your blocks, this is what's happening. You're basically turning off all the on buttons in the trigeminal caudate nucleus. And when that happens, that's powerful. You create a nociceptive quiet state, and that is your goal. And once you've done that, you've basically turned off all the triggering to the brain is caused by pain, nociception coming from the head and neck. And that's powerful because neurotransmitters have millisecond half-lives. And when they have nothing to react to and they go home, the brain is returned back to a non-pain triggered state, which is a powerful thing, particularly when you know where it's going to and what it does. The brainstem, the thalamus. The thalamus is going to direct information to the reticular activating system, the limbic system, the emotion system, and the cortex. And downstream, the sympathetic and spinal system is also being triggered, and these are also reset. So patients' back pain will actually feel better after these. It's pretty impressive. So let's sneak a peek at some data. We looked at about 5,000 patients in the past 4 years doing blocks, and really the ones we actually studied with chart reviews was a little bit over 300. And what we're really looking for is to find out who these patients were, who to target with these, so we could tell people who to think about using them on. And then finally, we want to find out how good they were, and we wanted to see how well they worked acutely and for how long they worked. And that's the most common questions. And then we started looking at some migraine-associated symptoms and triggers because those are very useful when you start looking at these patients to start thinking about these things. So early pilot numbers were my presentation from last year, and it was 161 patients. And we lost the data due to an IT problem, but basically it was compelling enough that I went ahead and presented it because the information was really so good that it really was going to be helpful just for discussion purposes. And the demographics were largely female, and the age was in the mid 50s. And that was interesting because it's a lot older than the average migraine cohort, which is between 20 and 50. So what's going on here is probably a hybrid between long COVID and migraine, because this is when we were looking at this during the throes of the early post-COVID pandemic. And these were significant problems for these patients, both frequent and severe. And a lot of these patients, 50% of these patients, had no prior treatment or diagnosis of migraine. And so they didn't think they had migraines. In fact, they didn't think they had headaches lots of times. They came in with sinus vertigo and ear pain as their primary symptom. And that's what it showed. It was equal with headache, with sinus, and vertigo was right behind it, ear pain and tinnitus and phantosmia and a bunch of other things, which didn't make the statistical significance to be on that chart. But it was information that was useful. Even though we lost the data, it did set us up to make a follow-up component of this study to really give us better information. So we looked at about 300 patients, and we had three phases we were looking at. One was alpha, delta, and gamma early Omicron periods. The second phase was during Omicron and later variants, and the third is the same time frame, but with a questionnaire on a tablet, which allows us to collect more information quickly and easily and collate it better. So that's where we're trying to go with this, to try to sort of systematically really look at these patients and get a lot of good data. And so we just need to make it easy and not laborious for the patients, because we do not want questionnaire fatigue. And so that's what we finally did. And what we found is there was in this data was a gradual shift towards more of a headache prone population, because that's the referral base I started getting, because this got out when I got mom's headaches better. The daughter came in and the grandma came in, dad came in. It was quite a yeah, a patient pleaser, but unfortunately, you can sort of create a little bit of a monster once you become that guy in a busy practice. But there's a way of managing it well, and I've sort of figured how to juggle that. But it's had some growing pains, and I'll share that with you so it doesn't become that for you. Learn from me. And then the data I found was pretty compelling. These were pretty miserable patients, and their triggers and associated symptoms are the things that we see. And so here's what we found. Female patients, middle-aged patients, getting a little younger in my migraine uh, demographic, but it's also probably because our long COVID is starting to get less severe. Patients are now becoming better herd immunized, essentially. So what's going on here is that now we see a lot more headache, but we still see the same usual suspects: the dizzies, the ear pains, the sinus, the ringing, the facial pain, the dysosmia. And then the secondary symptoms, which was very interesting, is not what they came in for, but what they also had that was significant, was a lot of TMD, a lot of neck pain, and a lot of auditory symptoms, and a lot of sleep symptoms. And that was very interesting. And they also had facial flushing and stuff like that, which we see from time to time. And people tell us their face looks swollen. We don't really see anything. We don't necessarily believe them. They start getting out their phone, showing us all these pictures. You block them, and all of a sudden, oh, my face looks normal again. And you're both say, okay, I'll take your word for it. But if that worked for you, I'm good with that. But my head feels better too. So it does happen, and it's sort of neat. And so here's the migraine associated symptoms that you'll see: a lot of brain fog, a lot of bad necks, nose, and jaws. Those are our bad triggers. A lot of vestibular and auditory symptoms, and also a lot of hormone symptoms. These patients are female, and a lot of dysregulation of their hormone axis is occurring, and they're having a lot of PMD and night sweats, the premenstrual symptoms as well. And those actually get better, but I don't want to advertise that because that's not the patient population I went into practice to treat. So, but it is an advantage. And these are the triggers. Here again, neck was the most common. These patients, as they got older, it's their worn out neck that's finally driving them to this point. But it's not usually the reason they're coming in. They got the dizzies, they got other things going on, and then their allergies and barometric pressure is playing a big role. You make a nose that's entirely tight, mad with allergies or an infection, that's the next thing that's going to happen is a migraine if they've already got sort of a migraine triggering going on. Plus, you can't escape a hurricane or tropical storm. When the pressure drops, your brain and meninges get traction on it, and that does trigger a migraine. So these patients are human barometers. And their management so far, we actually looked at that. It's very, very basic. I mean, I'm in South Carolina, but these patients are using goody powders and Advil and Tylenol sinus. And they're also, using a lot of antihistamines, which gives them sort of a false sense that it works, because it does sort of block mast cell histamine release, which does play a role in pain on the vessels. So it does work. And sometimes decongestants also act as a triptan. So it gives them this false sense that I got better on these sinus and allergy meds, so that must be what I got going on. And then their PCP also believes this, because most people treat, nasal stuff, like the grandparents do. There's not a lot of sophistication. And the relaxation technique was the best prevention that people had. It tells you people really aren't on board with this being a migraine type thing. And then migraine disability. These patients were severe. I mean, vast majority. And then, you need something if they're that miserable that would work. And this really works. Here's our numbers. Acute efficacy, 87%. My pilot study was about 73. Occipital blocks, you added on, it's over 95%. It's embarrassingly good. And my belief going on here is not so much that we're treating something where there's a placebo to occur. I think we're just basically proving local works. Because when you move the ball into the cup, when you put it in, you don't have to prove it went in the hole. It's the same like if you numb up an area and you pinch it with your AdSense or touch it with your scalpel and it still hurts, and you put more local in it and it works. We know lidocaine works. And I think that's sort of what's going on here from my own personal experience with this. When the cotton ball shifted and it's not quite right, I have Matt shifted and it's like, okay, I better. Within 30 seconds, you feel it work. And that's because that's what it does. It's local anesthetic. It's not placebo, because if it's not right. And when it is right, that it works. So I think that's what we're sort of seeing here. Even though we're doing a placebo-controlled trial, I think we're really sort of maybe a little too insecure with our own situation because everything else with migraine and pain is so placebo worrisome because those are pills. Treatment effect. It does have a neurochemical change on patients. But look how long this thing's lasting for. We're talking 13 and a half weeks in the pilot study, 15 weeks in our study that we did here, and that's on par, if not better than Botox. And we don't have to worry about the insurance coverage problems because blocks are covered because nasal endoscopy is covered. You're not charging for the block because you're not using anything expensive. You have to worry about that. The cost of goods is not worth the bother. Just get these patients treated and on to their neurologist. You don't have to continue to take care of them. You just need to let them know what they got. You can catch and release. And if it makes them better for 3 months or 4 months, hey, you can do it again. That's not a laborious patient. We see a lot of patients every 3 or 4 months, and it's not a big burden to us. And you can just make this so they just come in knowing what they need to a block clinic your physician's assistant does or your nurse practitioner, because this is not something they can't do. And then your second blocks will add duration. Adding occipitals adds about a month. And the more blocks you do, the better you get because you're basically getting them straightened out and they're getting better at the game because they learn a lot from this. And so your initial block's about 15 weeks. Your second block's about 18. Occipitals add about 15%, and in efficacy acutely, and adds about the same amount in duration, about a month. And so it's worthwhile adding on occipitals because they're not hard to do. And here again, cost of goods aren't much. And if you're non-specific with your diagnosis code, I'm telling you, you'll get these with no balking from the insurance company. Just use posterior neck pain. That's all you need. And the occipital block code is it easy, just occipital block code. You just can Google it, but I'll have it on my chart, on my slides at the end. Groups by duration. Well, here's what you find. There's some groups, well, it worked, but it wasn't much. They're sort of disappointed, but they at least know what they got going on. And the others, a bit better, but the ones over a month, those are worthwhile doing again because they're better long enough that this was better than most other options they've got. And then the success stories are really that. These patients feel great. They're really happy. They're your favorite patients of the day. They're happy. They're hugging your people. They're thanking everybody out front. They say it's worth the while waiting for this because you get behind a little bit doing that, but it's okay because you can sort of figure your way out to make that work for you. And just use the handouts and videos they give you to help sort of smooth out some of the time process. It took me time to make these, but you can use them or make your own. It's not hard. And then subsequent blocks last longer. So you're not something that's just going to continue to be there. It's going to eventually, my nurse's second block was 15 months, for gosh sakes. It's not laborious. It's like seeing somebody for a sinus problem. And then eventually, you start allowing them to manage themselves better because they at least know what they need to do. They need to know they have to work on their neck and pillow up and see the massage therapist and the neck specialist. And the TMD, you've got to sort of pay that attention to that. You got to get them to see their dentist and have them do an anterior bite plane and be good at that and be interested in that because patients that dabble in night splints don't do a good job with their over-the-counter options. They need to see somebody that not only their dentist does them, but likes doing them and does them well because they need to have trigger point injections and Botox in their arsenal. And then you need to treat their airway. We're good at that. There's nasal airways, what we do for a living. And their airway, if you do sleep apnea, manage it because if you can't rest, you can't get migraines going. But the ones that aren't lasting very long, the short responders, they're fine, but they sort of know their problem. They're still living like a rock star. They're not eating breakfast or staying up all night. They're missing meals. They're smoking and drinking. Yeah, they're not giving their brain the care it needs because they're 54 and they're acting like they're 24. And then, of course, a lot of them are out of control with their anxiety because they're lowering their serotonin. They have insomnia because serotonin is a precursor for melatonin, and they're melatonin deficient. And they have sleep apnea. They're wearing their CPAP. They're working night shift because they have to work 2 jobs. They're stressed out, and no wonder they can't get right. Their brain's starving, hungry, and underrested. And they're anxious, and they probably got psych disorder at this point from depletion of serotonin. They're anxious and they're on meds. And then sometimes they're not on the right meds and they need to do their homework there. And sometimes people get frustrated and get lost in the shuffle because life happens. A lot of these patients have just gone through a crisis, just had an illness. And then, and if you can't figure them out and if it's short lived, this is the ones you really think about imaging and get your neurologist involved with. And so once you start doing these, they become a pretty cool toy and they're easy to do. And they establish 3 things. This is a neurologic process. It can be turned off migraine or something like it. It tells you where it's coming from and what else is going on. what it is. It's it's a real game changer. You dizzy patients. And the patients who've come in with the TMD earaches, they're better and they know where it's coming from. They go see the dentist, you're done with them. The sinus patients work on their nose and their sinuses and the neurosensory issues. Now you sort of explain what those are because they oftentimes are a bit of a mystery. The clicking in the ear and all that. And the tinnitus, that's amped up out of nowhere. It really makes those patients better. Now, stable tinnitus, static tinnitus does not respond to this. Different mechanism, but they're quick, easy, safe, and effective. And that's why, this is what we do. So we should try to do these things. And the nose is our thing. And so this is what you'll learn when you're doing these things. They're all the same nose. They're all tight and narrow and crowded in the same places, creating high pressure zones that causes stimulation of pressure receptors, which the nose is loaded with. And these pressure receptors are hardwired to non-myelinated C fibers. And those C fibers have, among other neurotransmitters being released when they're stimulated, is the molecule CGRP, substance P, and a bunch of other stuff too. But CGRP is the one that's the big actor, we think. And it's because of what it does. It's an acute phase reactant that basically turns on the on button high to respond to toxin or injury. And so once it does that, it's made to rally troops and activate the nervous system to a sympathetic place. And so that's why blocking CGRP is a nice idea, and that's why those drugs work. And we'll talk more about CGP in a minute. But you treat the nose. These are all the same noses. Put them on nasal steroids. I put them on nasal steroids with budesonide, and I use the off-label use of budesonide in these rinses because I don't think nasal steroids work well in these patients. These patients are neuroinflamed and inflamed in general, and their nose is too tight for a saline spray to get there. Now, back in the 90s, early on, when they had aerosol sprays, they actually got there. They're an air gun, but a saline spray bottle is like trying to use Windex to clean the grill of your car. These patients need to be on rinses, but they need to get steroid in there to actually get anywhere. So I usually put them on budesonide rinses twice a day for 2 weeks to see what it'll do. And then afterwards, I start treating their allergies if they're present. I also treat their sinuses if they're present. Do CAT scans on these patients if they think their sinuses are infected to make sure there's not that going on as well, because a sinus infection can definitely trigger a migraine. And you can have both. So you would address that if you did nasal surgery, because nasal surgery does make sense in these patients. It's not contact point surgery. I don't think it's contact point surgery. It's narrow pressure zone surgery. Make the nose fit. Right now, these patients come in with the noses like a shoe's too tight in the summertime and they got bunions. And so you got to make the foot smaller because you can't make the shoe bigger because these are all narrow noses. And these noses are probably outlived their warranty. They're in their 50s. They're only supposed to live to 38. And most of these patients in South Carolina are patients from Northern Europe that migrated over a long time ago when it was cold up north and moved down south. And now they're living where it's hot and humid. And this nose was meant for Scotland. And so we're seeing a lot of patients in just a predicament where they've got a nose with no game and a bad nose to begin with. And so I get them all on rinses, try to explain them. Nose is the middle child of the face. You need to start taking care of it. We brush our teeth every day. So why don't you wash your nose every day with saline rinse? And you're going to use tap water if you have city water and you can drink the water. I'm not worried about the amoeba, not unless it's hot at night. And those are the reservoirs that grow amoebas, the patient, people in South Florida and the tropics, not up in South Carolina, certainly not up north. And these patients are all going to have the same nasal airway pattern. When you have a deviated septum and an narrow side of the nose, that's going to be the side they sleep on. They're not going to sleep well on their back very well. And if they do, they're going to clench their teeth real well to keep their tongue out of the airway. But when they're on their side, blood's going to go to the venous sinusoids of their turbinates. And if their nose is narrow on the downside, it's not going to affect them as much as their only good side is down. And then the bigger turbinate that's on the other side then swells up to block up the nose. And they don't have a side. Then they're back on their back and tossing and turning all night long. So the relatively symmetric noses tend to toss and turn, but the asymmetric noses usually sleep with their bad side down. And because of that sleep position, that's exactly the same position they have TMD pain in and neck pain in from work of breathing without support. And what happens is you get a lot of TMD ear pain on these same patients because they're sleeping on their pterygoid muscles that are pushing their jaw forward every breath they take at night to keep their tongue out of the airway. Because these patients that clench can clench because their lower jaw is far forward enough that they can use their front teeth to hold on. And when they hold on, you can see they've had veneers or chipped teeth, and if they grind back and forth too, they tend to have worn down lower incisors. You'll see these patients look like they have horse teeth up front. And then you put them in an anterior bite plane. If they have enough strong teeth, that'll hold their pterygoids at rest, which is very important. That way, they're not over fatiguing a muscle and sleeping on it and putting in a vice grip between their mandible and their pterygoid plate. And no wonder it hurts. Because if you do pull ups, if you squeeze on the muscle, it's sharp pain. The same thing happens to these patients. You mash on their insertion point of their deep masseter and their medial pterygoid. There's point tenderness, and it's very tender. It doesn't require a lot of pressure to do it. You just got to find a spot and they go, oh, wow, that's the pain you've been feeling in your ear. Okay, that's what it is. And then it recruits also the same muscles in their neck. So they'll feel the pain going down here, and it's their SCM and their stylohyoid, and all these muscles that are stored in that same area, mylohyoid, all get tender. And because they're under high pressure and high tension. And then, if they can't do right with their bite splint that they're wearing, they usually need Botox. And big muscle Botox helps these patients, masseters, temporalis, SCMs, traps, because the traps and the SCMs are playing a big role in this. Because when you just lay on the same side every night and the pillow's not high enough, this muscle gets mad at your neck, your head from having to hold it up all night long. And what happens is it gets tight and the muscle has the nerve wrap around it and it's just pulling on it. You're yanking on a nerve that's making the muscle hurt, and that's just a fist fight in the back of your head. And the traps are doing the same thing from having that pillow that's sort of varnish wrapped around a pillow, pulling on your trap. And then never mind that, then you get up, you start looking at your phone, looking down at your phone, and because we're higher primates, we have hands below our eyes are for our heads. So eventually our heads always get forward anyway. And so what happens is this is what's going to end the day for all of us. Worn out body parts, and particularly our neck. And so the greater occipitals from neck strain, looking down at things and not having the pillow, the shoulders ergonomically supported properly while you sleep. The one up top, it needs to have a big pillow to support the weight of the shoulder, and the one on the bottom needs to have two pillows between the neck and the mattress, and a little one underneath the arm so the arm can get out and not have the shoulder all wrapped around and pulled down on. And so that's the way I sleep at night. Package myself like a piece of china. Big pillow in front of me, one between my legs, two below my head, and one under my arm. I know it's a pain, but you know what? It beats having a neck that triggers a migraine. And then you got to do your homework on your neck, and I'll tell you more about that. But what about nasal surgery? That's what we do for a living. That's where it comes back to, okay, now I'm interested because this is what we do, and we do a good job when we do these if we do them right. Consider the nose a tight shoe. And so what you're trying to do is create more room in the places where they're tight. And these are all narrow noses. So it makes sense that right underneath the nasal bones, if we can make that straighter and thinner by taking the bone out underneath the nasal bones, and there's little cartilage there too. It's usually the bony cartilaginous junction is usually just beyond where the nasal bones start. You're not going to saddle those patients if you're pretty aggressive in that area. And I've found out from doing surgery now, doing these better by being more thorough in those areas on those patients, you'll take away the patients that have the V1 headache. A lot of pressure. They'll really, really improve. I know I improved after my nasal surgery. And then the turbinates, trim them out. Don't just leave turbinate that can swell up against the nose. So especially down south where it's hot and humid, I create a little bit more room by actually cutting part of the turbinate out. I don't do a submucous resection. I actually partially trim it and out fracture to get about 4 millimeters of laminar flow on each side. And then if there's a spur and there's a lower, shelf of septum, get it straight and thinner. The posterior nasal bone of the vomer and that spur doesn't need to be there. There's no reason for it to be there. If it's all causing pain, it's not doing any structural support. And that removal oftentimes alleviates some of those triggering points as well. So once you've done that, you've made three things happen. One, you've reduced the source of nociception. Two, you've improved sleep quality. And three, you've probably addressed one of their major causes of TMD and neck strain, sleeping on their same side every night. Now, if their nose is symmetric, they don't have a side. In matter of fact, because their airway's more open, they might be able to sleep on their back with a little thing under their nape and neck and their neck in a neutral position, which would be great for them because that'll really help their neck because that's going to be the lost cause for most of us is our necks that become the worn out body part if we continue to live longer. So these are the concepts I learned. The nasal anatomy tells a story. It'll tell you exactly where the pain's coming from, pretty much. And then every sense can have an R, functional loss. And neurologic slowing does this. We know this. Cortical spreading depression is the reason why people have auras. And it's more than just auras. We have brain fog. We have balance problems because balance is basically a video game. And when you slow that processing speed, it crashes. You can't play Madden on a whole computer. And finally, sensory hypersensitivity. These patients are amped up from an awareness center and emotionally also amped up. And when you reboot them, it's amazing what happens when you do that because there's really good data on what happens when you do an SPG block. You not only make the parasympathetics and sympathetics better, but you get a bump in serotonin. Central serotonin just bumps up and you drop your CGRP and nitric oxide. And that's powerful because these things cause headache and that causes anxiety. And what this is PMS, right? PMD. And so it helps that. So when you get PMD, what happens is it drops your serotonin and it bumps your CGRP and nitric oxide. That's why patients are more anxious and triggered and have more headaches during their preluteal phase, their luteal phase of their period or during premenopause. And then finally, the older you get, this is a truism in neurology. Mild and moderate pain tolerance gets better. Now we all know severe pain. We all feel a gunshot wound, and older you get, you don't tolerate severe pain long. But it takes longer for them to be triggered to have pain. That's why older folks don't need as much pain medicine after their surgeries. And so a lot of these patients will come in with very little headache with dizzies. So think about your older dizzy patients not necessarily having to have much headache. They may think they have sinus and their neck's going to hurt. And these are the observations you'll see. I think 80 to 90% of my patients that come in with dizziness nowadays have migraine. And now I know because I can prove it because I do blocks on these patients and I'll Hall pike them and Romberg them and then, do a head turn up and down, just see what their tolerance of optokinetic stimulus and vestibular challenge is because these patients have two patterns: intolerance to vestibular challenge and discrete episodes. But usually you're catching them when they're not having an episode. But between episodes, they don't tolerate things in front of their face. They don't tolerate head moving. They don't tolerate getting up fast, particularly. They have a very poor tolerance to orthostatic challenge. And this all gets better when you block them, unless they got other problems. But even if they have other problems, even that does better. Even the patients that have glove stocking neuropathy and proprioceptive loss from a bad back, they still do better because now their brain is able to process that bad information better. And then the ear pain, just palpate their pterygoid. That's TMD. Neck pain, here again, that's a good reason for the SPG failures. Don't be afraid of the occipital block. It's simply easier to start an IV, and we always try that when we can't get an IV on our kids in the operating room. And these patients aren't going to be necessarily wanting to have a needle in the neck, but once you let them know that this works better if you do it, then they're not too they usually say, okay, I'll let you do it because especially if you had done it yourself, and I can always tell them that. But it does really work. And the oral symptoms, man, these are so fun because you get somebody's tinnitus gone, they're really happy with you. And then the smell disorders, here again, those are fantastic candidates to try this on because we don't have other good stuff. I mean, smelling your spice cabinet and omega-3 fatty acids and budesonide rinses only does so much. It's really a flail because if you've lost smell, you've lost 95% of your olfactory epithelium. So what you're really getting really is an injury current. So when you turn off the injury current and then what meager level of olfaction is still there, then can actually penetrate through a non-busy signal, you can get something out of it. And I'm actually trying some of my patients on home blocks to see if it can actually continue to improve what little bit of smell they have. So other things to try it on is neuropathies, neuralgias, tremors, brain fog, anxiety, motion sickness, maybe hot flashes if your wife has them. So anyway, so what's up with COVID-19? I'm going to spend about 5 minutes on this to not belabor the point, but I think it's important to talk about because it's in the equation for sure. Um, so migraines were common to begin with. I mean, 1 in 6 patients had migraines, and now since COVID came along, we've seen an increase in incidence, and it's been documented in several studies, and it's been clinically evident in the patients we see. 60% more frequent, and 64% more severe. And this was early studies back in 21. Things have changed a little bit, but the thing is, now patients really aren't even paying attention to COVID that much and don't even realize they're having it because only 6% lose smell. But patients also don't exhibit the amount of headache that many of them think is a migraine either. So the recognition of it is also not good. But we see it, and we see it particularly after COVID and after the vaccines as well because of the same binding sites. And I'll explain where that's coming from to a certain degree. Migraines are, you know, already common, but if you've had the shot, sometimes the patients never had a migraine before and they started having the migraines, and that's 38% of these patients. So that's interesting. And then migraineurs, of course, they were more prone, and they saw that in at least 70% of these patients in the second or third vaccines gave them more incidence of migraine in that study. And that's sort of what we're seeing, and probably what many of us have experienced. But what's going on here? How did COVID change this game? You know, the thing about COVID is it's picked out some pretty interesting targets. The ACE2 receptor is more than just controlling angiotensin II with its blood pressure and vascular permeability controls, but also had impactful impact on other things and systems. And I'll go into that in a little bit of detail. But then, in the COVID times, that was just a headache waiting to happen anyway. Working from home and homeschooling your kids, there's nothing like that to create a headache. And then living like teenagers or like your kids, staying up all night and sleeping in and missing meals and drinking caffeine drinks. And that's not exactly a way to support brain health. And so you see a lot of headaches just by their very nature of that. But things have improved some as we've seen herd immunity occur and patients are getting less sick and as a result probably having less viral load and impact from that. But reinfections and boosters continue to restart the game in many patients and they'll come in with new symptoms. But what's going on in these patients? Well, we know that the patients basically had, the nose targeted by the virus, and then neurologic impact was directed from that point, and then you have a big virus that's hitting your system as well, which has a huge imprint. And the impact was problematic because of the viral binding sites, ACE2, CGRP to a certain extent, and myelin. And that's why we're seeing a lot of problems in the central nervous system. So the nose was ground zero, and we know that. That's why we tested patients with nasal swabs. And that was the initial idea that that was where it was really entering, but it's been noted to be entering in the GI tract and the lungs as well. But once it got to the olfactory cleft, it basically caused a metabolic, disaster by attacking the glia, which was the support structures for the neural system. And these patients correlated in headache. 50% of the patients more likely to have headache if they lost smell. And then the neural axis is not only through the olfactory cleft, but also through the nerves and the vessels. And once they get there, they create havoc where they go. And that's to the central nervous system directly through the olfactory system from bulb to cortex. You see demyelination in these patients, but also through the trigeminal system, which is targeted through the nose, which is hijacked by the process of a very inflammatory virus causing a lot of stimulation of inflammation and pressure. You see on myelinated fibers, here again, fire create a whole response largely orchestrated by CGRP. And then this dysregulation causes, a central nervous system that's now amped up and dysregulated. Never mind the fact the ACE2 receptor and being very sick caused a lot of patients to have systemic inflammation and clotting defects. And then from that, we see strokes, we see sick patients with encephalopathy, and we see sequelae of polyneuropathy and demyelination in these patients. And that's problematic. So the impact is actually seen on imaging. You see it in mild COVID patients will have substantial changes on MRI and PET scan. And this is not only global brain changes in brain size and brain health of gray matter thickness, but also in specific areas related to important things like sensory cortical centers, the amygdala and hippocampus involved with motion and regulation of homeostasis, and then the thalamus, which has access to the limbic and RAS, as we've talked about, and that is impactful. And so the neurology of this is part of it. But the other part of it is this whole inflammatory component. The virus is huge. It hit our system. It was like Jupiter hitting our system. That's why big viruses tend to do this. Epstein-Barr is another classic example. And this is not much different than, the chronic fatigue, Epstein-Barr chronic monotype picture here. We're getting an upregulation of inflammation that continues to persist in these patients due to basically what's essentially autoimmunity. But you have the classic response as well from a big virus. You get the big immune, cytokine storm from adaptive and humoral and cellular immunity responses. And many patients have already had a different version of coronaviruses growing up, and so this tends to be fairly brisk. And then you add the fact that this is particularly activating of the innate NK cell or monocyte system. You see that going on and persisting because this is a more primitive form of the immune system that I didn't know about in medical school. That I had to learn a lot about and doing my research. And that what it does is creates this sort of a very non-specific immune response at the cellular and systemic level. Cytokine clusters occur locally called inflammasomes, and these are turned on by nonspecific receptors to things that are like viral mRNA, right? or a flagella or a mucopolysaccharide of a bacteria. These are pathogen-associated molecular patterns. But there's also response to damage of the cell itself, damage-associated molecular patterns. And these all turn on through these receptors, nod-like receptors, and there's rig receptors, and these all basically turn on this sort of very primitive immune response at a local level, which creates a localized cytokine storm. It's a form of cell death called pyroptosis, which basically is an immune cell death, which explodes, or like a little mini supernova of cytokines. Pre-IL-1 beta and IL-18 are created there by caspase being bound by this virus's spike protein and also antibodies to it, and basically turns on localized hyperinflammation. And that creates in those areas significant oxidative stress and mitochondrial failure. And that's what's going on. And patients that are much more susceptible to mitochondrial failure are patients already with significant oxidative stress, patients with COPD, coronary artery disease, diabetes, and obesity. Those are the patients that succumb more to the virus. ACE2 is a ubiquitous regulatory inhibitor, so that's why it's so problematic when you bind it. It's not only turning down the tone on angiotensin and its hypertensive and permeability effects, but it also is a key regulator in other functions such as innate inflammation, as we talked about, coagulation, the clotting cascade, inotropy, apelin regulation. That's why you're seeing more arrhythmias and heart problems, and pain regulation at the kappa level, kappa receptor areas in the brain, which is basically causing unchecked pain, inflammation, clotting, and arrhythmias, which is what we're seeing in this world these days. And then this is what's going on. You take the ACE2 and you sort of take it hostage into the cell. You have to repopulate the ACE2 on the cell membrane enough to allow it to be back to where it was when you first got COVID. Never mind back to being good. And then, you know, even so, we don't really know what happens to the functionality when it gets brought into the vessel and into the cell. And that's sort of what they're still trying to work out. So it's still unclear, but it seems to be creating a hyperinflammatory state. Then the CGRP peptide is also playing a role in this. Never mind that it's highly concentrated in places where we're seeing this respiratory line and then central nervous system and the nerves themselves, but also in the gut, in the myocardium, and in the sex organs as well. So now you're seeing a lot of dysregulation because of CGRP being amped up as it's doing its job. It's an acute phase reaction to toxin and injury, and it lives in two forms, both in the gut and elsewhere, where basically it turns on the fight or flight response and rallying the troops to a toxin or injury by being a cytokine mobilizer, turning on the vessels to where it came from, a vasodilator, so it's potent vasodilator in the body, and activates the nervous system both peripherally and centrally the brainstem to pain. So it just amps up the signal and a response. And so what that does is it lights up the trigeminal caudate nucleus because that's where it's entering through the nose. And these patients wind up having much upregulated pain. So does COVID-19 enhance its role? The nose was ground zero. You make your conclusion. So if that wasn't enough, we see mimicry not only of the spike protein to the ACE2 receptor, but we also see it also in this really good study by Ezra Ozkan of the CGRP receptor. So isn't that interesting? Not only do you have CGRP being induced, we have it bound and turned on by the spike protein and the antibodies. Not only that, but also RAMP1, which is the amplifier. So it's turning it on high. So just flipping on all the switches to the pain amplifier, which is not a good thing. So we have a pain activated state that somebody's in a hyperinflammatory state. People are hurting more and inflame more, particularly in things that are already inflamed to begin with. Then, if that wasn't bad enough, no one talks about the nuclear capsid antigen, but there's significant mimicry and information about this being involved in what it mimics, the oligodendrocyte myelin. So we're seeing demyelination and glial autoimmunity in patients, even with mild COVID at 1 year out. That was the initial COVID classic. These are unvaccinated patients, but it's certainly concerning. But COVID lights up the nose because the nose is ground zero, and it's why it's probably creating a lot of anterior headache because it just triggers the C-unmyelinated fibers to release substance P and CGRP, and basically then turns on neurovascular inflammation to that area and primes the brainstem to that pain. And once that happens, the reflexes go through the SPG, which creates a lot of parasympathetic reaction with mucus congestion, tearing, lymphedema, etc., and increases sympathetic tone over time. So that's what we're seeing in these patients. But guess where else the ACE2 and CGRP also seems to be concentrated? Joints and tendons. So we see a high expression. We already knew this in both osteo and rheumatoid arthritis, but when you add this dysregulation of ACE2 and upregulation of CGRP in these places where it's already coexisting at a high level, we see pooling of inflammation and a inflammation system without breaks. So that's why we see things that are hurting more, particularly in places that are overworked. And in the head and neck, that's the jaw and neck muscles. And those are the number one and number two triggers for migraine. And so it's compelling. And then here's the data. If you got COVID-19, about half of you guys they got headaches. And if you got a headache, actually it was a good sign. That means you're probably going to survive the virus because you're mounting a good acute phase response. Those who got too sick just went through it and they just got too sick to probably notice it. And then finally, everyone has had either COVID or the vaccine now. And so what's basically happening is everybody has some of this going on to whatever level that their body would present with that, depending on probably their comorbidities to a certain extent, and also how sick they got and which virus they got. Did they get the COVID classic without any immunity, or did they have a breakthrough infection? They probably had a lot less of that response. But now no one even knows they're getting COVID because only 6% lose the smell, and no one cares that much anymore because unless you're getting back on a cruise ship, you're sort of not even getting the test because it's so 2020. And so what's happening is people are keep getting the virus and no one even knows it. And so what's happening is COVID's just sitting back saying, I'm just going to sit back and hold my beer, just watch me just continue to make you feel old because that's what it's doing. It's aging our body in a sense. And so 3 months plus of symptoms is how we define long COVID, but it's still a loosely defined, illness. It doesn't have a clinical marker that's of any consensus right now, but they're looking at IgG markers and IgM markers and monocyte markers, and these things are great, but they're not clinically generalizable. So we have a very nebulous condition, much like, chronic fatigue syndrome that we really can't nail down, but we know a significant component of this is headache and dysautonomia, and that's probably all part of the same process with upregulated inflammation, particularly in the problematic places and the symptoms related to that. The good news is that based on the statistics out of Minnesota, CIDRAP found about 30% incidence in 2021. It's now down to 5.3. And that means things are getting better. It's probably due to our body now becoming more accustomed to having COVID. And we've got good immunity to it. And to a certain extent, the virus has become less virulent, not so much because it's not as bad. It's just everybody now has a way to now at this point a way to mount a response to it, generally speaking. So you're not getting as sick, and hopefully as you keep getting new strains, it's going to outcompete the old strain binding it or old antibody binding it. Hopefully, COVID may actually fix itself by becoming so mild that it actually the next strain actually makes you do better afterwards. But we can only be so lucky. But the one thing we do see is that a lot of things are going on. It's not just one thing, and that's what makes it so difficult to diagnose and so difficult to understand. Because you got immune dysregulation, but you also have viral particle persistence floating around in monocytes, which continues to create immune response. Then you got activation or hyperresponsiveness to the viruses that already are present and the new ones you get, because your set point is now higher for all these things when they occur. Then the hormones are dysregulated, and that creates a significant strain on homeostasis. Cortisol and the sex hormones are deficient in these patients to a large degree, and so they all tend to crash in the afternoon when your cortisol nadir occurs. But there's also a nadir in your sex hormones. They're just different from male to female. Males crash a little earlier than females, so the nadir of cortisol and testosterone is around 5:36, whereas the females around 6:37. So you're all arguing over dinner. It's not a good time for anybody to be good because everybody's at their worst in terms of stress and running fevers in the evening. That's why kids run fevers in the evening. But this is a bigger deal. And then coagulation is a great dysregulation. Clots We see endothelial damage. We see autonomic dysregulation. We see a lot of POTS and arrhythmias. We see a lot of gut microbiome changes. And this is very interesting because there's some good data talking about malabsorption of tryptophan because of the virus and its effect on interferon. And that is a problem because that decreases serotonin absorption, which is a problem. Migraine patients are serotonin low. They tend to be more insomniacs because of the lack of melatonin created from serotonin, and this just worsens that situation. And then there's the mitochondrial failure, just generalized from inflammation and free radicals being created by all these areas of inflammation out of control. So this is a compelling story, and it's going nowhere, and we need a better way. So, I got sinus, earaches, vertigo. Yeah, we're going to continue to see that. We're going to continue to get the patients wrongly diagnosed and wrongly treated because people still don't understand this well, and we're still wasting a lot of time and money. And so we got to do something differently. So I told all my buddies about this in my practice and saying, look, this is a pretty cool thing. Gave a journal club on it, taught them how to do it, gave a good slideshow, and that was all great. And a few of them have actually done some, but no one's done it like I have to make it part of their routine practice. I'm a little concerned about that because I think we're probably just too busy to take on one more thing, but I get that. But this is one of those things that actually make your job easier, and we'll get the right diagnosis. I feel like as otolaryngologists, giving patients the wrong diagnosis is probably um, not okay. And so, I get this response. That's awesome. I'll just send them to you, dude. If I want to treat migraines, I get that. I mean, it's sort of like trying to talk toddlers eating to eat spinach, but um, you don't have to do anything but taste it. You can, you can give it to your friend, your neurologist. You can catch and release. You don't have to keep these patients. And so, at the end of the day, just make the diagnosis, educate them, manage your nasal airways, which you're good at. Do blocks, they're easy to do. Try some meds, at least acute meds, to get them out of harm's way. Get your migraine CGRP inhibitor reps in the doors to get you some Nurtec and Ubrelvy samples. They're very useful and they're cheap and easy once you get them approved. But now we've had a little nice thing happen to us. AHA got them to be almost first line, but you still have to fail a triptan lots of times. But if they have high blood pressure, coronary artery disease, you usually can get through that loophole. And getting something for nausea and getting some steroids is usually helpful. Preventative meds, here again, you can refer that out. If you don't feel like you're comfortable doing that, and before you start putting people on Topamax and nortriptyline, I get that. And then image the patient. Beware of the dangerous headache. Do not miss a dangerous headache. And then involve your colleagues. And so here we are. It's a whole team. We need a village to take care of migraines. It's not just your neurologist. We need your dentist. We need our head specialist. We need our, neck specialist. We need our hormone doctors for the estrogen control. We need psychiatrists and psychologists to get their neurochemistry right and to get them to use things like mindfulness and CBT. And also sleep doctors. We got to get the sleep right. We got to get insomnia fixed, and we also got to get their sleep apnea corrected. And the nutrition and gut specialists. Hey, listen, the gut is playing a role in this, and it's a great way to start working on wellness. But at the end of the day, we're not going to get a free lunch for this because they're going to keep on coming in. So we need a better solution. So migraines, they imitate a lot of the stuff we see, sinus balance and ear conditions and a bunch of other stuff. And if we had a tool to actually make it easier, why not use it? And we do. Laying in our office right now, cotton lidocaine and scopes. Give it a whirl. You got syringes and you got needles. The blocks are easy. Occipital blocks aren't something you should be afraid of, and they're not going to have a coverage problem as long as you're non-specific with the code. They're a very effective diagnostic tool. The next thing I do after a Hallpike and a Romberg on my dizzy patients, and they have significant advantages in that we are the ones doing it. We can see what we're doing, and we are trained to do this. We're cooking in our kitchen for once with this. Finally, instead of playing neurologists with meds, and we bypass the insurance barriers by just making it cheap and not charging for the block. We don't need a code for this because then they start putting rules. And then non-invasiveness, you can't beat it. There's nothing but cotton and lidocaine in your nose. You can put a string on it if you're worried about where it's going. And then cotton and lidocaine and nasal endoscopy don't cost much, especially if the nasal endoscopy is pretty much covered all the time. So thank you for your time. I know it's a little bit long, but I want to make sure that you got good information and not missing anything because all of it matters. Here's my most notorious migraine trigger, and she can probably answer the rest of the questions because she hears me talking about this too much. And then to learn more, I got you a training video, got a patient video for you to show your patients, and a video on a self-block technique using cotton and or Q-tips with forced lidocaine that you can usually get from a local pharmacist if they understand what you're doing with this. And you email me if you have any questions, and you can go to our website, which has resources as well. Thank you. And this is a great website for more information and resources and free posters and free handouts on the AMD website. And get involved. Get involved in the HEADS registry, the Migraine Science Collaborative, and Migraines and Otolaryngology Society. It's a great, easy, free sign up. They have a great forum on there you can bring cases to, and you can have high level experts give you their opinion. Thank you for your time, and get out there and do some blocks.